Thank you very much for the organizers for inviting me to come here. It's a lovely city. I booked a bike last night, so I went with the bike through Vilnius, and it's very beautiful. Thank you very much. I'm going to talk about vaccination for HIV patients, and probably you know, you know that WHO, beginning of this year, announced the 10 threats to global health, and this is air pollution and climate change, non-communicable diseases, global influenza epidemic, fragile and vulnerable settings, antimicrobial resistance, Ebola and other high-threat pathogens, weak primary health care, vaccine hesitancy, dengue virus, and HIV. So in the next approximately 20 minutes, I will actually, with my talk, touch 3 of the 10 threats WHO announced beginning of this year. The former speaker already said that there's a great vaccine hesitancy all over the world, and there's a group who looked at why are people not being vaccinated? And this is a map of the world, and I think Monsieur Macron would be very sad if you would see that in this map his country is dark red, meaning that the vaccine hesitancy is worse in France. And if you go on this website, you can actually put in the country. Unfortunately, Lithuania didn't give any, or there's no information about Lithuania, but really at the top is France, where about 41% of people say that vaccines are not safe. Then Bosnia-Herzegovina with 36%, Russia 28%. So these are the top countries. And I think before we talk about what to vaccinate, we just need to say we have to vaccinate, and there has been models designed to understand why is there such a big hesitancy. And I like the 5C model very much. It concerns confidence, so how confident do people feel with vaccinations? What are the constraints? So can people come in on a low level, in the morning, in the evening? Do they have to pay or not? Complacency, do people feel they are at risk of infectious diseases? Then calculation means, is there information about vaccinations, the pros and the cons? And I think very importantly, the collective responsibility, because we all know there are patients who can't be vaccinated because some form of immunosuppression. So you really need to encourage those people who are healthy and young to get vaccinated, to also so that diseases can't spread in the population. But now we go to the vaccinations in people living with HIV, and I think the most important thing is you should vaccinate your patients according to national guidelines. This is the first thing you should take home. And of course, there are infections which are more common in HIV patients. This is hepatitis A, like in MSM, IV drug use. You should, of course, vaccinate patients with a chronic liver disease like Hep B, Hep C infection against hepatitis A, because we see more severe causes and longer viremias in these patients. Hepatitis B, we've heard a lot about this shared risk with HIV, and we know HIV accelerates the cause of liver disease. Then HPV, papillomavirus, it's also shared risk with HIV. We see a much higher rate in HIV patients of cervical and anal cancer. Then influenza, there are high rates of pneumonia in HIV patients. Meningitis due to Neisseria meningitidis, as general populations. But then there's Streptococcus pneumonia. We see a higher rate and severity of invasive diseases. And to the end, varicella zoster. I think that's something we see, every one of us sees frequently. The severity of both chickenpox and zoster is much higher in HIV patients. In the coming minutes, I will not focus on hepatitis A and B. You've heard a lot about hepatitis B. There has been discussions about hepatitis A concerning whether if you vaccinate simultaneously, that the response is low. I think for hepatitis A and B, we've got very good serological markers. So it's really more a question, vaccinate, and you can look at the serological response. If it's not high enough, you just vaccinate again. So I would like to start, in the talk this morning, we heard about response to hepatitis B vaccinations, and this really correlates well to what I want to say. If you've got a patient who's got CD4 cells above 500, you don't need to worry. He will you can expect that he will have a normal vaccination response. If you've got a patient who's got CD4 cells between 200 and 500, the response will be pretty good. If it's below 200, it will be reduced. However, the question always is, do I wait till the CD4 cells have risen? Because we all know there are patients who will always stay below 200 all their life. So I think the better strategy would be to vaccinate, and if they come above 200, you just vaccinate again. The guidelines I show you today are the EACS guidelines, because I think these are the guidelines we all feel familiar with. And for influenza, EACS advises annual vaccination. And always in February, March, the WHO gives out the composition of the influenza vaccine. And in blue, you see the composition of the trivalent vaccine. In red, the composition of the quadrivalent vaccine. The reason to distinguish between trivalent and quadrivalent, I don't know. Can you just share up in which countries the quadrivalent vaccine is available? So there are many countries still where it is not available, and I just want to show you why this really makes a difference. So this is the subtypes which were there last year, and if we look at where we are living, it was mainly influenza A and very little influenza B. But the proportion of influenza B is changing every year, and you can never say in advance whether it will be influenza A dominating or influenza B. So if you look on the slide, there are years like 2005 and 6, there was 70% influenza B, and 2017-18, 68% influenza B. Why does this matter? Well, this matters because in the trivalent vaccine, there's only one strain of influenza B, and it can happen, and I think I need to lead you through this slide. So here you see the percentage of influenza B in each year. And if you look like in 2017-18, there's 72% of influenza cases were influenza B, and it was the Yamagata line, but in the vaccine, it was Victoria line. So that's what we called match and mismatch. So it's possible that influenza B is dominating, and in the trivalent vaccine, you've just got the other lineage of influenza B. That's why actually WHO said the quadrivalent vaccine should be used in all countries, but as we all know, that's not the reality. The other real problem is that still the vaccination coverage is very low, and here I show you some data from ECDC, and you can see that what we want in patients with chronic infections, be it rheumatoid arthritis, be it HIV, we want a vaccination coverage of 70%, and actually all countries lie very, very low below the threshold of 70%, and unfortunately it's like over 3 years, there's not much change going on. So I think that this is something we always need to keep in mind. We need to vaccinate our patients. The other problem is, and we've got a lot of data, I showed you the studies on this side, data on the swine flu, which was 2009, and we know that the seroprotection rate in HIV patients is lower than in other patients. And the other problem is we are often in shortage of influenza vaccines. At least this was the case in Germany last year. So we have got problems left, and I just want to point you to something. It's actually, again, a vaccine which comes from an Israeli pharmaceutical company. It's called the Universal Flu Vaccine. What is the background? It is designed to provide a multi-season and multi-strain protection, meaning that you don't have to vaccinate your patients every year, and you don't need to change the composition of the vaccine every year, making it easier also for the companies to produce the vaccine, because there's not so much change. Okay, we move on to Streptococcus pneumonia. Also, this is something which is, I think, very different in different countries of Europe. The EACS guidelines say you should vaccinate with the conjugated 13-valent vaccine. There's no recommendation for booster doses, but some national guidelines consider 1 dose of the polysaccharide vaccine. I just want to lead you a bit through this. Why do we distinguish these vaccines? So the one is conjugated and the other is a polysaccharide vaccination. And if you've got both available, you should always vaccinate with the conjugate vaccine first, followed by the polysaccharide vaccine, because it's called hyperresponsiveness. So if you vaccinate with the polysaccharide first, down here, you will have a lower response to vaccination than if you vaccinate with the conjugate first and then vaccinate with the polysaccharide. And it's easy to remember. It's the normal, how the numbers go, so first 13 and after this 23, if these vaccines are available in your country. So there has been a lot of discussion about HIV leading to higher rates of invasive pneumococcal infections, and I just want to show you 2 studies because it has changed a lot over the time. You can see that the people being under detection limit and having higher CD4 cell counts we are reaching higher levels, and in blue you see the rate of invasive pneumococcal infections, and you can interpret this that if the patient has got antiretroviral therapy, is below detection limit, has gained immune reconstitution, the rate of pneumococcal infection is even lower than in the normal population. So the risk of invasive pneumococcal infections really is something we mainly saw in the pre-ART era, and you see we are getting better and nearly back to the normal population. Neisseria meningitis, so they're in different countries, like England, they say everybody should get vaccinated. Germany is a bit back, they say only the children are vaccinated. The EACS guidelines said that you should vaccinate HIV patients with 2 doses, 1 to 2 months apart, and you should booster this vaccination every 5 years. We know that the serotypes of, or serogroups of Neisseria meningitidis are very different, spread over the world. So in Europe, we have mainly got meningitis type B, Neisseria meningitis, whereas in African region it's like W135. In MSM patients, and I just looked it up again for this conference, there are always like outbreaks of meningococcal diseases. So this goes over the whole world in New York, Paris, Chicago, Quebec, Los Angeles, Berlin. And although we would say Europe is like strain serogroup B, in this group of patients which was analyzed in Germany in 2014, we mainly saw meningitis serogroup C patients and strains. And I think you always need to keep in mind that if an adult and children, if they get invasive meningococcal diseases, it's a very, very severe disease, and more than half of the patients actually die. For meningococcal B, there are now two vaccines available. One is called Vaccero, one is called Tremember. Their composition is very different. It is suspected that the response to the vaccine with HPV subfamily A and B may be better, giving more protection against meningitis. However, at the moment, like in our country, we use them equally. Why I show you this picture is because Vaccero, the component of a Vaccero is different. There's one antigen called the outer membrane vesicle. And there have been there's one study done in New Zealand, and they actually only had this outer membrane vesicle in their vaccine. And we know that there's a large homology between Neisseria gonorrhoeae and Neisseria meningitidis, up to 80 to 90%. And actually, they could show in their study that the vaccination against meningitis was a protection against gonorrhea. And as we, with PrEP, see a rise in STIs such as syphilis and gonorrhea, probably you should think, if you think your patient is at risk of gonorrhea, think about vaccinating with Vaccero. There are studies going on to further analyze this report from New Zealand. Now we get to human papillomavirus. This is, I think, something which is a lot discussed. The EACS guidelines said that you should vaccinate with 3 doses up to age 26 and up to age 40 if your patient is MSM. You should use the 9-valent vaccine, but this age 26 or age 40, it's very long. So this is very different to Germany. We are only allowed to vaccinate the children until the age of 18. And if you vaccinate an HIV patient, you have to apply for payment, and the vaccine is very expensive. It's about 150 euro in Germany. So it's 450 euro for this vaccination. The prevalence, I think we often forget that HPV is associated with many carcinoma, 100% cervical carcinoma, 80% anal carcinoma, and approximately 5% of all human carcinoma are actually caused by HPV infection, mainly HPV 16 and 18. So there are now 2 vaccines available, one only Seroprotection, it's with type 16 and 18, and one Gardasil with 6, 11, 16, 18, and 5 others. Type 6 and 11 are low risk types. They are mainly responsible for condylomas, anal and vaginal condylomas. The safety of the vaccine has been shown in people living with HIV. They actually included 126 HIV-positive patients, children 7 to 12 years old. The children were immunologically controlled, and they saw a seroconversion rate for all 4 antigens in 96%, which is a really good result. However, the geometric means of the titers were lower. We don't know in which way this will impact the clinical relevance, but studies will show in the future what that really means. Why I pointed this out concerning the age. The HIV patients, if you look at the studies, most of them have a very high prevalence of HPV. So the question is it there? We know, so if you look at the study, 71%, 93%, 95%, so over 90% of the patients have been infected with HPV already. And there has been an ACTG study who actually looked at patients with HIV getting 3 vaccinations with a quadrivalent HPV vaccine, including 16 and 18, the high-risk ones. And they could see that HPV vaccinations in people living with HIV above the age of 27 had no influence on prevention of new anal HPV lesions or improvement of anal lesions. So they could find probably a role for prevention of oral HPV infections, but if you vaccinate a patient after who's older than 27 years old, you don't do him any harm by vaccinating him, but you can't tell him he's safe of anal cancer or vaginal cancer because the vaccination won't change the course anymore. Now I come to my last, have I still got 2 minutes? Which is Zoster, and I'm just showing this because there has been a big change. I won't go into varicella, perhaps I would just point out when vaccinating against varicella, so if you see that your patient hasn't got any protective antibody against varicella, you would vaccinate him. This is one of the very few live attenuated virus vaccines, so you shouldn't vaccinate any patient with a live attenuated vaccine if the CD4 is below 200. So the CD4 should be above 200 and above 15%, and the viral load should be negative if you vaccinate with a live attenuated vaccine. But for Zoster, actually the guidelines, the AIAX guidelines don't say anything because this is something which has just come up this year. The herpes zoster incidence, these are German data. The older the patients get, the more frequent comes herpes zoster and the post-herpetic neuralgia. And we know that the risk for herpes zoster is in chronic HIV infection is discussed to be 3 to 5 times. And I think really this is something we all see in our clinics. And until now we have only had the live attenuated vaccine, which didn't really have very good results. But now, since this year, there's Shingrix. It's a new type of vaccine. The immunogen is a glycoprotein which is on the surface of the virus. And if you've got patients who really are afraid of adjuvants and aluminium, all this, you can say this is a very natural vaccine because the adjuvants is a mixture of salmonella and of a soap bark tree from South America. So it's very natural, and probably you will be able to convince your patients to be vaccinated. There have been huge studies, they were published in the New England Journal of Medicine because you need a lot of patients to show that you can actually reduce the risk of developing zoster. So in one study there were 16,160 patients, and the other study 14,860 patients. I think this is amazing what kind of big scale studies you can actually perform. For HIV, because you couldn't, the only thing what they could do is that they tested what is the humoral response and the cellular response, because they couldn't include 15,000 HIV patients, but as you can see, also in HIV, you see a good humoral response and a good cellular response. It's very important to vaccinate the patients twice, so also for the humoral and the cellular response, the second vaccination is important. So I'm at the end of my talk. Vaccination is the best strategy for prevention. Vaccinate according to your national guidelines, and remember that HIV patients have got a higher risk for hepatitis A, B, human papillomavirus, influenza, meningitis, pneumonia by Streptococcus pneumonia, and varicella zoster. And I hope that on your way back you don't catch the flu. The vaccine is available now, so when you reach your home countries, I hope you got vaccinated. Thank you very much.